Hello everyone. My name is Kamal and today I'm presenting our work on improving the clinical prediction of surgical site infections or SSI. Our key contribution lies in a novel pre-modeling population construction framework that addresses one of the most persistent issues in clinical machine learning, which is severe class imbalance. So let's talk about SSI and its cost and risk. Surgical site infection is a major, often devastating post-operative complication. While there are a relatively low percentage of all surgical outcomes, the consequences are pretty enormous. SSI significantly increases patient morbidity, triples the average length of hospital stay, and imposes an estimated $3 to $10 billion annually in healthcare costs in the US alone. Current predictive models often rely on generalized risk factors, but our goal is to achieve personalized and not generalized and real-time prediction right before the surgery. If we can reliably identify a highly risky patient hours before the incision, we can implement targeted preemptive interventions to mitigate that risk, making SSI a more preventable problem. The fundamental hurdle in this domain is severe class imbalance. In a typical surgical cohort, the vast majority of patients do not develop an SSI. SSI is the minority class. For the dataset used in our study, non-SSI cases outnumbered SSI cases by over 20 to 1. When we train a standard machine learning model on this imbalanced data, the model takes the path of least resistance. It learns to predict the majority class, which is no SSI, because that is the safest and most statistically frequent answer. It becomes a prediction model for good outcomes, not for the risk. This results in a model with high overall accuracy, but very poor recall for the minority class. It misses the patients who actually develop the infection. We needed a way to construct a balanced and clinically relevant training population before we even introduced the classifier. Our core innovation is the patient similarity framework for population construction. The big idea is simple yet powerful. Instead of using all 20 non-SSI patients for every one SSI patient, we will only select non-SSI patients who are clinically analogous, patients who are highly similar to the infected patient in every way except for the infection outcome itself. We are essentially creating a highly refined domain-aware control group for our training set. This ensures the model isn't learning generic factors like all patients are over 50, but is instead learning the subtle difference between two highly similar patients who underwent the same procedure, where one developed an infection and the other one didn't. This focuses the model on the true risk signal. We can take a look at the example here. If all the data points in orange, blue, or green are negative, and positive patients are shown in red, then the model selects the data that is highly similar to red, which becomes orange. Our data comes from electronic medical records of 4 hospitals, so there is some stratification across providers, although they all are within the same health system. Therefore, we limited our features to only contemporaneously available structured electronic medical record data, specifically historical diagnosis code, also known as ICD-10, and procedure codes, also known as CPT-ICD. Crucially, we excluded less timely features like post-operative lab results, clinical notes, or imaging. Why did we do that? Because if the prediction is to be actionable, it must be available at the time of the surgery, not after. Features that only become available hours after surgery are useless for preemptive intervention. By limiting ourselves to codes that define the patient's history and the current procedure, we ensure our model is deployable in a real-time clinical setting. So how do we quantify clinical analogy? We treat each patient's historical electronic medical record codes as a binary feature vector and use established similarity metrics. What metrics did we use? Jagged similarity is excellent for sparse binary data like electronic medical record codes. It measures the size of the intersection, shared codes, divided by the size of the union, total unique codes. If two patients share many codes and have few unique ones, the Jagged score is pretty high. The other metric is cosine similarity, which looks at the angle between the two patient vectors. It is highly effective at determining proximity in high-dimensional space. By calculating both, we get a robust two-pronged measure of clinical similarity between every SSI patient and every non-SSI patient in the cohort. The output is a rank-ordered list of potential matches for every infected patient. With the similarity scores calculated, we move to the construction phase. For every single SSI case in our training set, we select the top n non-SSI cases ranked highest by the similarity metrics. In our primary experiment, we used the ratio of 1 to 1, meaning the top one most similar non-SSI case was paired with each SSI case. This process accomplishes two vital things. First, it creates a perfectly balanced 50-50 training set, removing the statistical bias towards the majority class. Second, and more importantly, it ensures that the non-SSI cases are now highly relevant clinical matches. The model is forced to distinguish between two patients who look nearly identical on paper, rather than distinguishing a healthy patient from a sick one. The outcome is a high quality, relevant, and balanced cohort that isolates the true risk signal. For the final classification, we utilize CATBOOST, which stands for categorical boosting. Categorical boosting is an ensemble technique known for its excellent handling of categorical features, which electronic medical record codes are, and its built-in mechanism to prevent target leakage and reduce overfitting. It's a robust choice for clinical data, allowing the model to effectively leverage the clean, balanced, and relevant feature set created by our patient similarity framework. This is the most critical methodological point, and it's essential to address it head-on. A common critique of this approach is, by filtering your controls, you are introducing selection bias and making your training set unrepresentative of the real population. Our counter-argument is simple. We are not introducing bias. We are replacing a statistically uninformative bias with a clinical principled bias. The original imbalance data set already contains a bias, a statistical bias towards the majority class, where the model learns nothing about true risk. Our framework, though, deliberately introduces domain knowledge into the sampling process. In epidemiology, studies rely on matched case control populations to isolate variables. Our patient similarity approach is a machine learning implementation of a matched case control study design. We are filtering out the noise. Patients who are so fundamentally different from the SSI cases that they are irrelevant to the risk question. We are creating a training environment where the model is forced to identify subtle risk factors in a clinically equivalent population, leading to a more generalizable model of risk, not just an accurate model of non-SSI. In other words, we filter noise, not signal. This isolates the true risk factors. The similarity is not making the final decision. The classification model is. Thus, the similarity method simply reduces the majority class's noise in the training data. Now let's see how the performance was. The proof of this methodology is in the results. Our primary metrics, given the clinical urgency, are AUC, area under the curve, and F1 score. Result 1 shows that the AUC achieved over 90%. This is very strong performance for a prediction model relying solely on timely, readily available electronic medical record. Result 2 shows that the F1 score and balanced accuracy were high. This is also crucial because a high F1 score confirms that our model is not just accurate overall, but that is successfully balancing precision, avoiding false alarms, and recall, catching actual infections. This balance demonstrates the success of the patient similarity framework in overcoming class imbalance. So what does the comparative advantage say here? When we compared the patient similarity framework against conventional methods like random undersampling or simply training on the full imbalanced population, the patient similarity model dramatically outperforms them. Conventional methods, while balancing the data, often lose vital information because they randomly discard non-SSI cases. The patient similarity framework, though, ensured the non-SSI cases we kept were the most informative controls. Ultimately, the patient similarity model produced a clinically superior model, specifically demonstrating exceptional improvement in SSI recall, the ability to flag an infected patient, while maintaining high overall specificity. In summary, our study established 3 key takeaways. Number 1, we successfully built a highly accurate and practical SSI prediction model using only timely, structured electronic medical record data, ensuring it is ready for real-time clinical deployment. Number 2, we validated the patient similarity framework as an effective, principled, and domain-aware technique for overcoming severe class imbalance in clinical datasets. It is a powerful alternative to random sampling methods. The combination of this framework with the robust CatBoost classifier achieved top-tier performance, AUC over 90%. For future work, we plan to explore refining the similarity metrics using deep learning methods to create more nuanced patient embeddings. We also need to proceed with external validation across different hospital systems to prove the model's generalizability. Thank you so much for your time and attention.